Hi everyone, my name is Dr. Syed Raza Kazmi and I'm a pediatrician. This video lecture is designed to give an organized approach to neonatal hypoglycemia, the most common metabolic problem in neonates and the leading cause of admissions to the neonatal intensive care unit. So let's start with the clinical case. Now you are on your NICU rotation and you are called to see a baby Lily who was born 2 hours ago at 39 weeks gestation to a mother with gestational diabetes. Now, apart from gestational diabetes, Lily's mother's pregnancy and Lily's birth was uneventful. You're called because she has a blood glucose level of 2.2 millimoles at 2 hours of age. Now, what would be your next step in this particular case, okay? And we will review the answer to this case at the end of the podcast, okay? Now, the objectives of this lecture are that after listening to my lecture, you should be, number one, recognize which infants are at risk for neonatal hypoglycemia. You should know how to diagnose neonatal hypoglycemia, recognize the signs and symptoms, and know which infant should be screened for neonatal hypoglycemia and how that screening should be performed. Now, normal glucose homeostasis, we will start with an overview of normal glucose homeostasis, okay? Now, maintaining appropriate blood glucose levels is extremely important because the brain uses glucose as its primary fuel, and therefore sustained hypoglycemia or very low glucose levels can lead to brain damage. Now, main hormones responsible for maintaining glucose are insulin and glucagon, but epinephrine, cortisol, and growth hormone also play an important role in glucometabolic. Now, in response to high blood glucose levels, insulin secretion from beta cells in the pancreas is increased, and this stimulates the liver to store glucose as glycogen. Now, when blood glucose levels are low, glucagon secretion from pancreatic alpha cells is increased, and this stimulates glycogenolysis and gluconeogenesis, therefore increasing the release of glucose into the bloodstream. Now, during times of starvation, amino acids from muscle stores can be used for gluconeogenesis, and fatty acids can be broken down to produce ketone bodies, which is an alternative fuel source for the tissues of the body, including the brain. Starvation also stimulates the sympathetic nervous system, thus causing the release of adrenaline from adrenal glands, which increases the release of glucose from the liver. Then finally, in periods of prolonged hypoglycemia, the body secretes growth hormone and cortisol. These hormones reduce the rate at which body utilizes its limited glucose supply. In utero, the fetus receives a constant supply of glucose from its mother via facilitated diffusion through the placenta. The fetus produces its own insulin in order to maintain glucose homeostasis in the womb. After birth, the constant supply of glucose that the baby was receiving from its mother stops abruptly, and therefore, in order to prevent hypoglycemia, neonatal secretion of insulin must be regulated. In the healthy newborn, serum glucose levels will drop in the first 2 to 3 hours of life and then will spontaneously increase and subsequently be maintained by regular feedings. It is not unusual to see low blood glucose level in the first 24 to 48 hours of life as the baby adjusts to life outside the womb. Now, we call it transitional hypoglycemia of the newborn, as seen in 10% of healthy term infants. In asymptomatic babies without risk for neonatal hypoglycemia, which we will discuss later, these brief periods of low blood glucose are assumed to be benign. Defining neonatal hypoglycemia, I would say that neonatal hypoglycemia is defined as blood glucose level below 2.6 millimoles in the first 72 hours of life. And beyond that, glucose levels less than 3.3 millimoles after 72 hours of age. However, it is difficult to determine exactly what glucose level indicate neonatal hypoglycemia, and a single number cannot be applicable to all infants in all situations. The clinical presentation of neonatal hypoglycemia can range from a completely asymptomatic infant to central nervous system and cardiopulmonary disturbances. There are two general categories of symptoms of neonatal hypoglycemia: the neurogenic and neuroglycopenic. The neurogenic symptoms happen as a result of sympathetic nervous system stimulation in response to hypoglycemia, so are also called as adrenergic signs. They are the first symptoms to appear, occurring at higher blood glucose concentration than the neuroglycopenic symptoms. Neurogenic symptoms include jitteriness, pallor, temperature instability, irritability, and tachycardia. The neuroglycopenic symptoms happen as a result of decreased glucose delivery to the brain and include episodes of cyanosis, convulsions, intermittent apneic spells, or tachypnea, a weak or high-pitched cry, hypotonia, lethargy, and sometimes coma that may lead to death if the hypoglycemia is not corrected. Now, severe recurrent neonatal hypoglycemia can cause permanent brain damage, and it can cause cerebral palsy, personality disorders, occipital lobe epicephaly later in the life. Because other conditions such as sepsis can cause similar symptoms to hypoglycemia, it is important to document hypoglycemia and confirm whether symptoms resolve with the administration of glucose or not. Now, the risk factors for neonatal hypoglycemia can be grouped into three categories. Babies who are too large, too small, or too sick. Infants that fall in the too large category include infants who are large for gestational age, we call them LGA, and infants of diabetic mothers. Now, infants who fit in the too small category include infants who are small for gestational age, less than 10 percentile, and those who suffer from intrauterine growth retardation, and those who were born prematurely. Infants who suffer from sepsis and infants of mothers with eclampsia or a condition like chorioamnionitis are also at increased risk of hypoglycemia. Maternal labetalol use, asphyxia, and late preterm exposure to antenatal steroids are additional risk factors. Two most common causes of neonatal hypoglycemia are excessive insulin production and inadequate glycogen stores. In both of these situations, gluconeogenesis is impaired. Excessive insulin production or hyperinsulinism is the most common cause of neonatal hypoglycemia. It occurs in two large categories, including infants of diabetic mothers and macrosomic infants. These infants receive a large supply of glucose from their mothers in utero and therefore must produce a large amount of insulin in order to maintain glucose homeostasis. Now, this can cause hypoglycemia after birth as the infant continues to produce large amounts of insulin in the absence of large glucose supply. A rare cause of hyperinsulinism is a congenital disorder called persistent hyperinsulinism hypoglycemia of infancy, PHHI, in which the normal relationship between blood glucose level and insulin secretion is disturbed and insulin is released even at low blood glucose levels. Other less common conditions like Becker-Weidman syndrome and Sotos syndrome can also lead to hyperinsulinism. Now, inadequate glycogen stores are another common cause of neonatal hypoglycemia. Infants who are in the too small category, such as those who are born prematurely, those who are small for gestational age, or those with IUGR may have low hepatic glycogen stores, low muscle stores, and low lipid stores to be used as substrate for gluconeogenesis and ketogenesis. Similarly, infants who experience perinatal asphyxia or starvation may deplete their glycogen stores and be unable to produce glucose through gluconeogenesis. Other causes include neonatal hypoglycemia include increased glucose use, which can happen in hypothermia, sepsis, or polycythemia, can happen in growth hormone deficiency, cortisol deficiency, inborn errors of metabolism, adrenal insufficiency, poisoning, drugs, or systemic disease. Now, screening is important because neonatal hypoglycemia can lead to severe consequences, and it is important to know which babies should be screened. For the purpose of screening, a cutoff level of 2.6 millimole for at-risk infants in the first 72 hours of life is used, as blood glucose levels below this are associated with adverse outcomes, especially if it is persistent or repeated. During the first 2 hours of life, infants should not be screened for neonatal hypoglycemia, and it is important because unless and until they are unwell or symptomatic, if they are unwell or symptomatic and have a blood glucose level of below 2.6, the infant should not be fed and treatment should be initiated immediately. After 2 hours of age, if the infant is well and is not at risk for neonatal hypoglycemia, routine care should be given, including feeding on demand. Infants should not be tested unless they become unwell. Infants who are at risk of neonatal hypoglycemia like LGA, infant of diabetic mother, SGA, IUGR, preterms, blood glucose levels should be checked at 2 hours of age, after at least one effective feed, and then every 3 to 6 hours after that, before feeds, provided that the infant remains well and glucose levels are stable. We aim for blood glucose levels above 2.6 millimole in the first 72 hours of life. If the level is below 2.6, treatment should be considered. When blood glucose levels are greater than 2.6, child should be fed on demand. In this case, treatment is not indicated. However, glucose must be monitored. In infants of diabetic mothers or large for gestational age, hypoglycemia usually occurs within the first 12 hours. Therefore, glucose testing cannot be stopped if levels have been consistently above 2.6 millimole at 12 hours of age. Now, infants who are small for gestational age or premature, hypoglycemia usually happens in the first 24 hours of life. In these cases, testing can be discontinued if glucose levels are consistently above 2.6 and regular feeds have been established by 24 hours of age. Now, coming to some common questions regarding management. Usually people ask us, what are the treatment options for neonatal hypoglycemia? Now, that includes increased breastfeeding frequency, supplementation with donor breast milk, formula or 40% dextrose gel, IV glucose, and in persistent cases, some pharmacological intervention. Frequent breastfeeding on demand should be encouraged in at-risk infants in an attempt to prevent neonatal hypoglycemia. If mild hypoglycemia occurs, then increased frequency of feeds plus minus supplementation may be all that is needed. Another question which is asked is, if infant screens positive for neonatal hypoglycemia but is asymptomatic, then how should they be treated? Now, if an infant is asymptomatic but the glucose level is less than 2.6 millimoles at 2 hours of age, the infant should receive 0.5 mils per kg or 40% dextrose gel with a feed. Or alternatively, for those centers not employing dextrose gel, a breastfeed and a measured volume of 5 mils per kg of a feed may be offered. Glucose level then should be rechecked 30 minutes after the feed. If the levels are now below 1.8 millimoles or the infant is not tolerating, IV dextrose therapy should be given. If the levels are between 1.8 and 2.6, the infant should receive another dose of 40% dextrose gel and another feeding or breastfeed with an increased measured volume of 8 mils per kg. If levels are still below 2.6, 30 minutes after this feed, IV therapy should be considered. Now, what if the infant is symptomatic? Well, if the child or baby is unwell or symptomatic, glucose is less than 2.6, should not be fed and should be treated with IV dextrose immediately. Now, in symptomatic infants, 40% dextrose gel may be used as a temporary measure to raise blood glucose while waiting to establish an IV line. Another question usually asked is, how would you manage a baby who requires IV dextrose therapy? Now, the Canadian Pediatric Society guidelines say that you should start with a 10% dextrose solution at 80 mils per kg per day, which is equivalent to 5.5 milligram per kg per minute of glucose. And a single bolus of 2 mils per kg of 10% dextrose solution over 15 minutes can be used to reach target glucose levels more quickly, especially when the baby is symptomatic. Blood glucose then should be checked every 30 minutes after initiation of IV therapy. If greater than 2.6, it should continue and monitored every 3 hours. When glucose levels are above 2.6, enteral feeds can be introduced as tolerated, and IV dextrose therapy may be slowed down, may be weaned off when the child has been stable for 12 hours. Pre-feed glucose monitoring should be continued until the infant is on full enteral feeds. If blood glucose levels are less than 2.6 after 30 minutes of IV therapy, rate of infusion can be adjusted in a stepwise fashion till the blood glucose levels reach above 2.6 millimole in the first 72 hours of life or above 3.3 millimoles after 72 hours of life. It should be monitored every 30 minutes. In the first 72 hours of life, breastfeeding can be continued without risk of overhydration because the volume of colostrum is small. In supplemented infants, in order to avoid dilutional hyponatremia, total oral and IV intake should not exceed 100 ml per kg per day. Another question is, when should you consider using pharmacological treatments or referring to a specialist? Now, if the glucose infusion rate of over 10 to 12 milligram per kg per minute is required to maintain glucose level, further investigation should be performed in order to identify a possible endocrine pathology or inborn error of metabolism. That means referral to an endocrinologist or a pediatric metabolic specialist, and it should not be delayed. Pharmacological intervention in the form of IV glucagon should also be considered if glucose infusion rate of 10 to 12 milligram per kg per minute is not sufficient to maintain the glucose levels. And if glucagon is used, it should be either given by IV bolus at 0.1 to 0.3 milligram per kg or by infusion at 10 to 30 micrograms per kg per hour. Alternative therapies include hydrocortisone, diazoxide, and octreotide. However, there is limited data to support their use for initial management of hypoglycemia. After the transition period, when the infant is over 72 hours old, the therapeutic blood glucose target is greater than 3.3. In infants with persistent hypoglycemia, a blood glucose level below 2.8 millimoles should prompt further investigation with a critical sample. Now, a critical sample is a panel of blood tests to find the cause of persistent hypoglycemia and must be collected while the infant is hypoglycemic, and that includes a confirmatory plasma glucose, beta-hydroxybutyrate, bicarbonate, lactate, free fatty acids, insulin, growth hormone, cortisol, carnitine, and acylcarnitine profiling. For neonates being monitored for persistent hypoglycemia, precautions should be taken before discharge from hospital. They should have a 5-6 hour fast before discharge with a blood glucose level above 3.3 millimole, 4 to 5 hours post-feed to ensure their safety at home. In addition, an underlying cause of their hypoglycemia should be determined and specific medical management should be initiated. Parental counseling is also important about the frequency of feeding, glucose monitoring, signs of hypoglycemia, treatments of hypoglycemia, including medications if necessary. Now, let's return to the clinical case, okay, which I gave you earlier. Now, here, Lily is infant of gestational diabetic mother, a major risk factor for developing neonatal hypoglycemia. Her blood glucose level was checked at 2 hours of age, and you note that she does not exhibit any signs or symptoms of hypoglycemia. Now, because her glucose level was 2.2 millimole, which is below the cutoff level of 2.6, and she is asymptomatic, you give her a dose of 40% dextro gel and encourage her mother to breastfeed her on demand. You recheck her blood glucose level 30 minutes later, and you find it increases to 2.9 millimole. Now, you should continue to check Lily's blood glucose level every 3 hours prior to feed until she is 12 hours old. If the glucose remains stable and she is fine, she can be discharged the following morning. So let's review main learning objectives, okay? Our objectives were to recognize which infants are at risk for neonatal hypoglycemia, how to diagnose transitional persistent neonatal hypoglycemia, knowing the sign and symptom of hypoglycemia, which infant should be screened for neonatal hypoglycemia, and how screening should be performed, and to know how to manage transitional persistent neonatal hypoglycemia. So the takeaway points are that the most important risk factor for neonatal hypoglycemia are being small for gestational age, large for gestational age, intrauterine growth restriction, being born prematurely, and being the infant of mother with gestational diabetes. Transition-related hypoglycemia is defined as blood glucose level below 2.6 millimole in the first 72 hours of life, and persistent hypoglycemia is defined as blood glucose below 3.3 millimole after 72 hours of age. And there are two main categories of symptoms of neonatal hypoglycemia. The neurogenic symptoms include jitteriness, pallor, temperature instability, irritability, and tachycardia. The neuroglycopenic symptoms, which you should remember, are apneic episodes, episodes of cyanosis, hypertonia, unresponsiveness, lethargy, seizures, a weak or high-pitched cry, and coma that may lead to death if hypoglycemia is not corrected. Infants should be tested for neonatal hypoglycemia immediately if they are symptomatic or unwell. Infants with risk factors for neonatal hypoglycemia should be screened at 2 hours of age, and then every 3 to 6 hours after that prior to feeds. Testing can be discontinued after 12 hours of age if LGA or infant of diabetic mother, or 24 hours if SGA, IUGR, or preterm, if the blood glucose levels remain constantly above 2.6. For asymptomatic infants with blood glucose level of under 2.6, initial treatment should include increased frequency feeding, supplementation with 40% dextro gel along with the feed. Measured volume of 5 ml per kg of feed along with breastfeeding may also be offered. If this is not successful in raising blood glucose level, then you can consider IV dextrose therapy. For infants with asymptomatic hypoglycemia, IV dextrose therapy should be initiated immediately. If IV dextrose therapy is not successful, other pharmacological interventions may be necessary. And infants with persistently hypoglycemia beyond 72 hours of age should be investigated further when their glucose levels are less than 2.8 and should have a therapeutic target of greater than 3.3 millimoles. Before discharge from hospital, they should maintain blood glucose level greater than 3.3 millimole per liter after a 4 to 5 hour fast to ensure safety at home. So these were some of the takeaway points for neonatal hypoglycemia, which you should always remember. I hope you have learned something from my video postcard. If you liked it, just subscribe to my channel, or you can ask me questions in the comments box below. If there is any further question, you can ask me. Thank you very much.